That would be really great because, as I say, there's quite a lot for me to go through, and I do this on the FRCS hand course.
Yeah.
I've obviously put a lot of different slides in as well now, just so it doesn't repeat, but it is quite exhausting that would be really yeah, so that's we're now live on YouTube, so that's good. Excellent. And then at 8 o'clock we'll just get started. Good. Yeah, if you could field them, and then at the end, if there's any, you can ask me, but we kind of might run out of time. You might just have to email me.
Yeah, that's fine.
Great. And there was somebody else going to be a panelist, wasn't there? I thought
yeah, I'm not.
Don't worry, we don't. I just don't want you to have to do all the work.
That's okay. I'm not. We did. I think there was somebody else. I can't remember exactly who it was. I've put a message on the group anyway.
Yeah, no, don't worry, it's fine.
Yeah.
And then I'm not sure what we're doing next week. I'm away next week, and where we're staying, I'm just not sure what the Wi-Fi is going to be like. Hopefully it's going to be fine, in which case we may do another hand topic, but then we've got pelvic trauma coming up, 1 or 2 sessions, and then pediatric orthopedics, 1 or 2 sessions. So we've got a fair bit to go, but
yeah,
quite a lot of people are away for this week. Hopefully there's nobody away in Spain.
Yeah, no, oh my gosh, difficult, but kind of potentially semi-expected, like if you go away in the midst of a pandemic.
I know, it's crazy, right? They generally thought it was going to be okay, and gosh.
Yeah, I know, and now we're going to have to isolate.
Crazy times.
Yes. So.
Are you going away at all?
No, we've just decided to stay local, to be honest. My husband's a dentist, so he's effectively been furloughed, although not, because it was all really difficult. And now he's just going back to work normally, so we've kind of done this with our leave, but yeah.
A huge backlog of cases, I'm sure.
Yeah, he's full already until near enough November.
Wow, well, that's all right. Good. Well, we'll get started because it's 8 o'clock, and can you see that?
Yeah.
Great. Okay, so it's 8 o'clock, everyone. So we'll get started because we've got a fair bit to go through. Hi, Jason. Nice to see you.
Hi, nice to see you too.
Thank you for joining us. If you could field some of the questions, and then if we have time at the end, I'm pretty sure I'll be exhausted, as will other people will be exhausted at the end of this, because it is quite hard going speaking for this long on this many slides. So welcome everyone to another evening with the FRCS Sunday Supper with Wrightington in association with BOTA. It's been really good fun doing this and supporting you. And as one of my colleagues, Puneet, said, to thank you all for all your hard work through these really difficult times. And we know it's severely affecting your training. So it's just our way of trying to give you a bit back. And obviously we're going to keep this going in the long term, because I think we've had amazing feedback. So this is a hand slideshow spotter that I've been doing for the last 20 odd years as part of the Wrightington revision FRCS course. And we found it quite useful. We usually show about 70 or 80 slides, and then I just talk about what a common question would be asked by an examiner, and then perhaps what an answer would be. But sometimes I don't even say what the answer would be. It's just so that you can see sort of the level that you're wanting to go at. And we all know that the level is day 1 consultant, and it's not a post-fellowship hand surgeon or a 5-year hand consultant. It's a day 1 consultant walking into fracture clinic, sort of running the show. So let's get started. When you first start as a trainee, this is kind of your knowledge. You've got no paint on your on your screen, and then someone teaches you a bit about an ankle fracture, and you kind of do an ankle fracture, and you know a bit, and you're really pleased with yourself, and you perhaps do a DHS or something, and then after year 2 you're getting a bit more confident, you do a few more jobs, and you learn a few more tricks. Year 3 you learn a bit more still. Year 4 you're really starting to motor, but there's still a lot of blue on the canvas that needs filling in. Then you apply for the exam and you start to get a little bit panicked, so there's a little flurry of knowledge acquisition there. And then a week before the exam, you're really starting to motor. But you can still see there's lots of gaps in your knowledge. There's still a lot of blue canvas there that hasn't been filled in with your white knowledge. And then the night before the exam, you'll be in the hotel and you'll be all meeting somewhere, probably socially distancing, just talking about something. And one of your colleagues will tell you something that you had no idea about. You've never even heard it. It's as though it was a different syllabus. And you have got 2 options. One is to completely panic and think, oh my God, I didn't know any of this. But the other thing is to listen and say, well, tell me about it. And you now know it. And that's a really important positive thing, because that will happen right up to walking into either the written or into the exam. You're still learning knowledge right up until the very last minute. So do not panic. Just keep on getting that knowledge coming into your brain all the time. What do you wear? Some people say you just kind of want to look completely and utterly like everybody else around you. You don't want to have any standout features. A jazzy shirt, a jazzy suit, a jazzy dress. You just want to look grey, just so you just fit in with everybody else. And what I always say about this exam is clinical examination is absolutely key. And we can learn as much knowledge as we like about all these different things. But if you can't fundamentally examine a normal joint going into quite a senior exam, you're in a lot of trouble. And quite often in the exam, there will be shoulders and there will be hands and there'll be hips and knees that are painful. And after 2 or 3 candidates have examined that joint, it starts to become a little bit wearing for the patient. And the patient starts to think, I'm just not sure I can do another candidate coming through. And of course, the examiners, doesn't want to cause unnecessary discomfort. So what's the examiner going to do? They're going to suddenly start to ask the next candidate, this lady's got a painful right shoulder, and she's been examined by a few of your colleagues today, and I don't want you to examine her painful right shoulder. I want you to examine her normal left shoulder. And it's as though you've been asked a trick question and people suddenly freeze. But you haven't to freeze. You've got to think this is a slam dunk, because I have examined 1,000 normal shoulders, and you've got a pattern that you could just go through, whether it be a shoulder, a hip, a brachial plexus. You might be asked to examine a normal joint only because the patient's got a painful other joint. And then, of course, they can start to talk about signs and what have you, move on from there. But don't be surprised if you're asked to examine a normal joint. So whenever we do the exam, we always start off with a settler question. And every lecture I do, I tend to put a little bit of pink and purple on it. It just makes me feel a little bit more academic. And some of them, those of you who know me certainly know I am not academic. And this would not be a settler, okay? A settler question that I used to ask candidates when I was an examiner, I would say, what's this? And they'd say, it's an arm. And I'd say, that's very, very good. Can you go a bit further? And they'd say, it's your right arm. And I would say, you're doing extremely well. And what's that? Left arm, right? Excellent. And it's a way for us just to settle the candidate down into the exam, and then we can start to increase the depth of knowledge. So don't be surprised if you're asked a very, very simple question to start, and it's called a settler. So here we go now. We'll get into the main thrust of this slide spotter. So here's 2 different x-rays of a patient's thumb. And you can see that we all know that this is a Bennett's fracture, and it's unstable. And it's not unreasonable for us to ask you, this is a 42-year-old right-hand dominant male, he's injured his right hand, how are you going to manage this? And we would start to talk to you about the options, and whether you'd fix it, whether you wouldn't fix it. And of course, we would want you to talk about fixing it. We perhaps would want to ask you about why that fragment remains where it is, because the very strong beak ligament is holding it in place, and the metacarpal sublux is off. And this would be a way that we could fix that, just with simple exposed or buried K-wire fixation. And we might then start to talk about, would you bury all your wires? Would you sometimes bury them? Would you ever offer internal fixation? And these are all, none of them are wrong answers. It's just us discussing, have you been around the block? Have you seen a few of these? And this is a left thumb. It is a right thumb. And the patient presents with pain on the inside of their thumb. And you can see on the bottom right-hand corner, there's obvious laxity of the ulnar collateral ligament. And we will start to say, can you tell me about this injury? What do you know about it? And we would hope that you would talk to us about ulnar collateral ligaments and potential stena lesions. We might ask you about what investigations, and we do an X-ray. And an X-ray would look to see whether there's a bony fragment. And remember, the bony fragment comes off the volar ulnar corner. It's not sort of mid-axial. The insertion of the ulnar collateral ligament is obliquely volar and ulnar. So that's where the fragment comes off. And they can be very difficult to fix back on just because of the angle. This is an MRI scan in a sportsman. You can see they've pulled their ulnar collateral ligament off with a little tiny bit of bone as well. And this may or may not be a stena lesion. But this is a stena lesion. And you can see a McDonald has gone underneath the adductor aponeurosis. And then just below between the McDonald's and the retractor is the ligament. And so we need to now incise that adductor aponeurosis to allow the ligament to be reattached down to its footprint. And I like to supinate the thumb to deliver the volar aspect of the base of the proximal phalanx for me to reattach that. So that's called a stena lesion. And that will not heal. So that ligament is not able to get down to its footprint. It's kind of avulsed and has flipped out onto the wrong side of the adductor aponeurosis and will not reattach. And then we may then go on to talk about a slightly more advanced case, and we may start to say to you, what are the principles here? What would be the most important structure? How would you manage this? And we would hope that this would get reduced in A&E. If it didn't get reduced in A&E, why might not it get reduced? Well, there may be an interposed volar plate, and it may need open reduction. And we would expect you to start to talk about the ulnar collateral ligament as being probably the most important ligament for reattachment on this. And so we'll say this is a patient that presents on a Saturday night, early hours of Sunday morning, having been in a bit of a fight the night before on Friday night. You can see there's quite a bit of induration. And we would want you to talk about what the potential injuries are here. And of course, we're all trying to get to, it's a fight bite. And even if the patient has told you that they did this tripping up, going down the street, we would be very concerned that this is a fight bite. And of course, the human mouth is very toxic. There's lots of organisms, and you should know what organisms are in the human mouth, and therefore what antibiotics you would want to start the patient on. And all of these do need surgical exploration. It needs opening up, and it needs opening up down to the capsule, and then debriding, washing out, and either leaving open and closing a few days later. And that's probably the safest thing to do. You'd only ever close the capsule if you could easily close the capsule and you were absolutely convinced that there was no deep-seated infection. So then it's not unreasonable for us to show you a distal radius fracture. And then what we would say to you is, this patient is presented to you. She is, we just make up an age, 45, right-hand dominant, shopkeeper, slipped on some ice and has got this fracture. Can you talk to me about what you see? And so what we would want to know is how you're going to manage this being the day one consultant. And I'd want you to tell us about what are the poor prognosticators for displacement. Why is it unstable? Well, there's dorsal comminution, there's shortening, there's dorsal angulation and loss of radial inclination. And there's an associated ulnar styloid. And we would want you to say, I would want to improve this position. And then we take an X-ray and we could possibly monitor this for the next few weeks without any further intervention. We could wire this, or we could offer this fixation with the volar locking plate. And then we want to check that the distal radial ulnar joint is clinically stable by doing an AP glide and then radially deviating the wrist and then checking the DRUJ again. That was the Derby test for DRUJ instability. I think I've got that on YouTube somewhere. So those, so don't be expected to see a distal radial fracture in the exam, and just to talk about the principles. And then we may go on to what are the long-term consequences of distal radial fractures with a malunion. And here you can see the radial metaphyseal scar. It's healed, but it's healed with some shortening. And they've now got secondary ulnar plus variance. And the ulnar is abutting against the lunate with this quite classic ulnar abutment syndrome. And we may want to talk to you as an advanced case about how you would manage this. Would you purely do a radial osteotomy, lengthen it and correct the angulation, or would you combine that with a ulnar shortening osteotomy? And we would probably look to talk to you about that sigmoid notch on the radius. It doesn't look very favorable. It kind of looks as though if you shorten the ulnar, you may get some problems. So we would hope that you get a CT scan on that just to see whether that would be possible. We may talk about complications of metalwork. This was a non-union, the old pie plate from a long, long time ago. And obviously, the patient's gone on to have difficulties. And again, KY fixation. And this was a poorly done attempt at fixation. And I think you should understand about the draft trial and the comparison between internal fixation and KY fixation for distal radial fractures. Now, what I do want to tell you about is a true lateral radiograph. And it's really nice in the exam. So you can you're kind of fishing with the examiner. So if you know something that you think the examiner wants to hear you know that you know, you could say that this is a true lateral of the wrist. And they may pick up and say to you, well, why is it a true lateral? And the reason why it's a true lateral, Galula described that if the pisiform is within the shadow of the scaphoid, it's a true lateral. So you can almost imagine an inexperienced radiographer taking that X-ray and thinking, oh, that doesn't look quite right. The ulnar looks as though it's, that should be lined up. So she may, or he may twist it ever so slightly to get the radius and ulnar in alignment, thinking that that's now a true lateral. And then the pisiform would obviously then come out of the shadow of the scaphoid. So that's why that's a true lateral. And it's sometimes nice to use the words, rather than just say this is a lateral, say this is a true lateral, and even quantify it to them, because the pisiform is within the shadow of the scaphoid. And it's kind of putting you on a different level than the person before you or the person after you. Metacarpal fractures or finger fractures, and this is showing some rotatory deformity. And so even in an acute fracture, you can often ask the patients to very gently make a fist and straighten it. And all the nail plates should all be parallel with each other, whereas this one's slightly tilted, but they should all kind of point towards the scaphoid tubercle. And that's quite a nice way to assess for rotatory deformity. And then fifth metacarpal fractures are extremely common. And we see quite a few each week, and we've got to know which ones need fixing and which ones don't need fixing. And the way I like to talk about it is explain that the index finger to middle finger is very rigid. There's virtually no AP play. But as we go across to the ulnar side, there's huge play. And you all see that there's huge play on the little finger. So you can accept a much greater deformity in a little finger metacarpal fracture than you can on an index finger. And I'm sure there's lots of papers out there that tell you what degrees are acceptable and what are not acceptable. For my mind is if it's about 40 degrees, 30 to 40 degrees, and you can feel a palpable metacarpal in the palm, I would then look to fix that. And the way I fix them is under general or regional anesthetic or local anesthetic, is reduce the fracture by just pushing the thumb against the metacarpal head. And then I do a K-wire, a blunt pre-bent K-wire down through the base of the fifth metacarpal, make a little drill hole in the base, and then pass the K-wire along the metacarpal. So it's an intramedullary sort of bouquet pinning is what we call it. And you can usually get 1.6 K-wire, and occasionally you can get another 1.1. I tend to bury them under the skin and remove them at a time in the future once the fracture's healed and if they're causing irritation. Sometimes we can just leave them. I think trying to fix these with plates up close to the MCP joint is fraught with stiffness. So I've got, I very rarely offer internal fixation close to the MCP joint for fear of stiffness. So this is a transscaphoid perilunate dislocation, and quite rare injuries, but they often make good conversations in exams. So you kind of need to know about Mayfield's classification and understand all about that. But this patient will present with carpal tunnel syndrome in A&E. And so the patient has a high energy injury with a lot of pain and carpal tunnel syndrome. This is what you should be thinking about. And in this case, they've ordered radiographs, which has shown that the lunate is dislocated volarwards. And this, you would attempt a reduction in A&E, simple traction, or an attempt at manipulation, just to get over that first aid period. You may even need to take them to theatre to try and reduce it. And very occasionally, they need to be reduced through a volar incision and release the carpal tunnel at the same time. And then once it's back in its place, you can then refer that on to a hand surgeon. So we wouldn't expect you to know how to treat that in the long term. It's just those first aid measures, reduce the lunate, reduce the carpal tunnel symptoms, and then refer it on. And there's Mayfield's, which you're all familiar with. And then a scapholunate ligament injury. You can see there's a large gap there between the scaphoid and the lunate. And there are some figures that are banded about, and it's thought to be 3 millimeters. But what I would try and get across to the examiner is it's not just the 3 millimeters. You want to look at all the other intercarpal distances, because the patient might have 4 millimeters all over their wrist. And therefore, if you just stick to that 3 millimeters, you're being very prescriptive. So I would say, well, it does look more than 3 millimeters, and it does look more than the other intercarpal angle. So I do think it is a true increase and diastasis. And you can see here that the scaphoid has separated and started to flex. And you can see that ring sign of the scaphoid. And then the lunate is starting to extend. And then on a lateral radiograph, we would see this so-called DC deformity, where the lunate is tilting backwards and the scaphoid is flexing forwards. And these are what's called tomograms. Okay, we don't do these anymore. These are a historic slide from the Mayo Clinic, and I'm grateful to them for letting me use these. But you can see that the scaphoid is extremely flexed, and that is where the pattern of arthritis is. It's right on that proximal pole of the scaphoid and the dorsal ridge of the radius. And there's the lunate extending, and now the capitate is starting to pop out. Okay, so they all kind of need reducing. So this patient presents with a laceration on the inside of their little finger. And we would say, what do you see? And you'd say, well, I see a laceration. And you could even go and be bold to say in zone 2. And if you say something like zone 2 to an examiner, there's only one thing that's going to happen to you. You're going to get asked, what are the zones? Which is fine, because if you know them, you're kind of playing with the examiner. You're setting these little, you're fishing, you're setting these little tiny traps, which are all great if you know, but if you don't know the answers, that it's not great. So the examiner will say, well, what do you see? And the word we want you to say is the loss of the normal cascade. That's a kind of a buzzword. So the little finger's straight because the flexor tendons, the FDS and FDP, have both been lacerated. What else might be injured? Well, obviously the ulnar, the radial digital artery and radial digital nerve. And so we ask the patient, do you have normal sensation on the inside of your little finger compared to the outside and compared to the other side? And the patient will say, no, it feels a bit abnormal. It feels a bit woolly. And we often like to grade it. If 10 out of 10 is normal, what do you feel? And they may say 2 out of 10. But then the Bic Biro is a really good test as well. And this looks to see whether they're sweating. So if the nerve has been damaged, as well as the artery, the sympathetics go on the artery. And therefore, if the sympathetics have gone, the finger will be dry and your Bic Biro will slide off the finger very quickly because it's dry. If they're sweating, there will be some friction because of the sweating, and you'll compare one side with the other side. So that's the Bic Biro test. Now then, this is another finger injury, loss of normal cascade, but there's no laceration. And this was a rugby player. So what we would ask you, and this is another rugby player, and with the ring finger, and we would say to you, what has happened here? On this particular finger, you can see there's bruising over the volar aspect of the pulp, because that's where FDS has been avulsed. So you get a bit of hematoma there, a bit of bruising. But also, if you look in the palm, just proximal to the A1 pulley, there's a bit of bruising there and tenderness. That tenderness is not necessarily the stump, because the stump is usually at the decussation of FDS and FDP. That's usually where it goes back. And that's letter packet classification, and it gets held up in the chiasm of FDS usually. But that around the A1 pulley is just usually where some of the hematoma is coming out. And here's a patient now presenting, and another one with a ring finger. I'm not sure whether it will play the video, and you can see they can't flex their FDP. And the ring finger is the commonest one, and there's a number of reasons why, theories why it may be. So just kind of have one in your mind, but generally speaking, you know, it's poorly understood why the ring finger is affected. We always do an X-ray. This just showed a pretty smashed DIP joint, but also if you look halfway down the proximal phalanx, you can see a chunk of bone as well. And so this was FDP that had been avulsed and had retracted with a bony avulsion. This is a flexor tendon of FPL. I think it's in a rheumatoid patient that we repaired. I'm just flying through these. And then we may start to ask you about the blood supply to tendons. We may start to ask you about the type of tendon suture you would use, whether you, how many core sutures, how many strands you would do, and whether you need an epitendinous suture. And it's Bo Tang's recent work that you really should sort of have he did a great review article and read that, because that has kind of changed the way we're thinking. Sure, we want a 4-strand technique, but we're less obsessed with the epitendinous suture that we used to have. Almost we want the repair to be slightly bunched up rather than perfectly in line, because we know we can vent the pulleys now ever so slightly, which is more important. What we don't want is any catching. So the majority of these flexor tendon injuries are now performed wide awake under local anesthetic with no tourniquet. So local anesthetic with adrenaline, so that on table we can get them to move their fingers, and we can look to see whether their repair is starting to gap. Because if it starts to gap in the OR when we're operating on, it will almost certainly rupture. So I'd rather know about gapping when I can do something about it than 2 or 3 weeks down the line. I would rather know about catching on a pulley now in the theatre when I can do something about it than in 2 or 3 weeks' time when their finger's stuck and is not moving. So I think that would be a really good thing for you to get across the examiner, is that flexor tendon repairs are now increasingly being done wide awake under local anesthetic because of the ability for those reasons. And also because of COVID, you know, that's pushed a lot of people into doing Wallant surgery. WA, Wallant, wide awake, local anesthesia, no tourniquet. So this would be a reason, but you know, every fracture clinic's going to have one of these. It's a mallet finger, and you're going to have to know how to manage a mallet finger. We always do an X-ray, and you know what is appropriate to fix it and what's not appropriate to fix it. And there was a paper a couple of years ago that did put a bit of controversy on it, but I think the safest thing for the exam is to say if that fragment is a third or more of the articular surface, you want to consider fixing it. And particularly if there is volar subluxation of the whole of the distal phalanx, as seen there with those lines, that's an indication to fix it. Of course, you could say, well, we'll just put them into a mallet splint or get our hand therapist to make a thermoplastic splint and re-X-ray. And if it all lines up pretty well, then you may want to go down a conservative line. But I think a reasonable answer for you to say a third of articular surface or more, or if there's volar subluxation to the distal phalanx, you know, it's an unstable fracture, and I would look to do something. And this is another one associated with a P-long fracture to P1, so it's slightly more complex. But this was basically just to show you how I fix bony mallets. I do a dorsal blocking wire. So I don't try and get a screw into that little fragment into the distal phalanx, because I've got 2 pieces of bone. If I put a screw in and it cracks, I've now got 3 pieces of bone. So I try and keep it simple. So I put a little tiny dorsal blocking wire just to hold it down in place. I then reduced the distal phalanx and put a retrograde transarticular wire across. And then that was just a distraction external fixator for the PIP joint to get them moving as soon as they can. And then proximal phalanx fractures are really tricky to deal with internal fixation. And quite often we will certainly try traction splinting. And this was I think it was a cyclist who came off, and I asked him to send me a picture. I didn't expect him to send me a picture in the bath. I only saw this afternoon. I looked at it again. I thought, oh gosh, there's baths, soap suds underneath. And he's not quite caught the traction splint. But basically, we put some zinc oxide along either side of the little finger. So one on one side, one on the radial border, one on the ulnar border, beyond, and then we twist it so it makes a cord. And then we secure it on so that we can actually give good traction. We put a thermoplastic splint along the front of the finger and then pull the cord over the thermoplastic splint, which has got a groove in the end. So we put a few knots along the cord and then pull it over. So you can look online to see traction splints. And he kept that on for 3 or 4 weeks. And you can see it lines up pretty well. And again, we don't really like plates around joints because of stiffness. So we avoided all the stiffness, and he did pretty well. So this is my finger. This is a volar plate injury. And we'd like to, talk to you about the volar plate, how it's got a fibrous half and a concertinaing part, and how we should always get an X-ray, because even small avulsion fractures can do really badly. And the risk for a volar plate injury is fixed flexion contracture. So you should always tell the patient there is a risk that your finger, may start to curl over the next 6 weeks. And it's certainly worth referring on to a hand therapist early, before the contracture starts. So if it does start to occur, they're already in the system, and the therapist can make them a thermoplastic splint or even a dynamic type splint. But even with the best hand therapists in the world, seeing them every day or every week, these patients can still sometimes, unfortunately, get a fixed flexion contracture. This is a rugby player with a distal biceps rupture. It's from a long time ago. And you can see it's through a longitudinal incision. Now, I don't do elbows, but my colleagues do it through very small transverse incisions. And the take-home message here is that the patients lose supination. So the examiner would ask you, what functional loss will this patient lose? And they won't lose power of flexion of the elbow because of the huge brachialis is still intact. It's supination that they lose. Okay, so you may want to explore that. So this is a sportsman who's injured his wrist, and I think this is one of the best signs for assessing a wrist injury: lack of wrist extension. So if someone's got a true lack of wrist extension, you've got to assume that there's some internal derangement in the wrist until proven otherwise. And obviously, it's commonly a scaphoid fracture, or it could be a scapholunate ligament injury, or it could be something else. But those are the two common ones. And then when we get a scaphoid fracture, it's just worth getting the two hands together and asking them to pull their thumbs up in the air to show the anatomical snuff box. And quite often with a scaphoid waist fracture, there's a hematoma in the wrist. And the waist of the scaphoid is actually at the base of the anatomical snuff box, because that's where we press looking for bony discomfort. And that will be filled in with swelling and hematoma, and you lose the soft tissue contours, as you can see here in a scaphoid fracture. And we would want you to know how to examine for scaphoid fractures, the various areas of tenderness, and Joe Dice's paper showed us all about that: the anatomical stuff box, axial loading, telescoping, tubercle tenderness, etc. So we certainly want you to know how to manage a scaphoid fracture as a day one consultant. This is a waist fracture. To me, it doesn't look a happy fracture. It's quite a steep fracture, and I would be concerned that could displace. But you've basically got to know in your mind how you would treat fractures. And I think it's safe to say that all proximal pole scaphoid fractures, you would say, are fixed. all displaced waist fractures you would fix, and undisplaced waist fractures, you might say we could treat this in a cast. And there's a randomized control trial ongoing at the moment. It may even have early results out at the moment, showing probably no difference between internal fixation versus cast immobilization. But what is displacement? You know, how do we quantify displacement? And it's very difficult. I think it's fair to say if you can see the fracture on an X-ray, well, it's probably displaced. So you may want to get some advanced imaging, such as a CT scan. And then if you can't see a fracture in A&E, you either put them in a cast and wait 10 days the old way, or quite often you'll now send them around to an MRI scanner, limited sequencing, and you'll see whether there's a fracture or not. So those are the sorts of things you want to be talking around with scaphoids, is making the diagnosis, how are you going to manage them in a suspected fracture, an immediate MRI, or delayed and re-X-ray, and then how you're going to manage them. And as I say, all proximal pole fractures, you really would want to consider fixing them, displaced or undisplaced because of the high risk of non-union, and you'd explain because of the retrograde blood supply. All waist fractures, undisplaced, it's dealer's choice, and it's not unreasonable to treat them non-operatively, but I think a displaced waist fracture, you would probably want to fix them. And then we'll talk to you about non-unions and what happens in non-unions. And there's two different types of non-unions. The one on the left is that fracture that you saw just earlier, and it's gone on to quite a severe non-union, increased sclerosis of the proximal pole. The one on the right, you can see it's really well corticated, so it's obviously very old. And then we might want to talk to you about how you would fix these, whether you bone graft them, what type of screw, wire fixation, where you would take the bone graft from the hip or from the distal radius. And a couple of my colleagues at Wrightington wrote up there was no difference between bone graft from the hip or from the radius. I always tend to go from the radius because I almost happy that I'm doing a corticotomy to an adjacent bone to increase the blood supply, just as my limb reconstruction colleagues would do that in the tibia. If they were doing some lengthening or bone transport, they do a corticotomy. So if I go to the radius, I'm inducing increased blood supply to the whole of the upper limb, and therefore hopefully improve my chances of union. And that's what's the so-called humpback deformity, where the scaphoid flexes on itself. Approaches, generally speaking, for waist fractures, you want to go in from the front, just to reduce that humpback. And then for proximal pole fractures, you want to go in from the back. And that's just a broad principles that you would probably want to know. And then this is a patient that's had a percutaneous scaphoid fixation done elsewhere. And you can see there's the scar, very small. It was just a K-wire across the scaphoid, and the screws are very, very sharp, and took out EPL. And what we've asked the patient to do here is to retropulse their thumbs off the table. You can see on the patient's right, so on your left, you can see normal EPL, and on the other side, you see an absent EPL. And so that's why most hand surgeons, even though we say it's through a percutaneous, we always do it through a mini dorsal. We see EPL and move it out of the way because it's sitting right where we want the screw to go through. Hook of hamate fractures, they're pretty common really. They're obviously common in racket sports people, such as hockey players, golfers, and baseball players. And the handle hits them across the hook of hamate. And what they present with is a kind of a deep-seated aching over the hook. They present usually with pins and needles in the little and ring finger, and they present with discomfort on resisted flexion of the little finger. And that's on account that the flexor tendon is running very close to the fracture site. And it's not uncommon sometimes when we excise hooks to see a little bit of fraying of the flexor tendons to the little finger. And the reason why they get pins and needles is because of localized edema and swelling pressing on the ulnar nerve, which is sitting right next to the hook. So that's almost a slam dunk case. I hit a baseball, I hit a shot out of the rough, I hit a tree root, got discomfort here, pins and needles on the front, only on the front, because remember the The dorsal sensory branch of the ulnar nerve exits proximal to Guillen's canal, so just on the front, and it's painful on resisted little finger flexion. Now, how would you treat a hook of hamate fracture? I think it's not unreasonable in a non-pro sports person just to treat them in a cast immobilization or a splint for 4 to 6 weeks and see if they settle. And probably, I don't know, probably about half of them do and never need anything further. And the other half probably have a grumbling discomfort and will need the hook excising. In a pro sportsman, almost always we just excise the hook. It's extremely rare that anyone would want to fix this, although I have seen a few case reports, but there must be a high non-union rate because it's quite a small contact area. It's a high risk operation because there's a bit of clockwork on either side, and it's far simpler just to excise the hook, be very careful of the neurovascular bundle and the flexor tendons. And you need to excise the hook right down to its base. So you need to make sure you take the whole of the non-union and a little bit of the hamate into the base of the hamate. You don't kind of want to just take the tip and leave the non-union, if you appreciate what I'm saying. So Kienbock's disease is a really common exam viva case. I do remember there was one when I was an examiner, there was a Kienbock's in the exam, and all she had, the only clinical signs was loss of wrist extension. And again, that's how we pick, if you loss of wrist extension, there's something going on in the wrist, and that was her only clinical sign, and a bit of tenderness over her lunate. We seem to spend 20 to 30% of every hand surgery conference talking about Kienbock's for something which affects about 0.1% of our clinical practice. It's just kind of a topic where there's classifications, Littman's classification. We really want you to know that, and we kind of want you to know how to manage it, even though it's a rare condition. So this is a clinical photograph of an adult male, and it's showing a little tiny bit of pitting in the palm, and we might say, what do you think is going on here? And we would hope that you would say this is early Dupuytren's, and we would say, how would you manage this? And it's not unreasonable for you to take a history, and we would want you to know the age. So if this is a very young person, so if this is someone in their 30s, we would want to know. If it was someone in their 50s, 60s, we're a little bit less cut. So if it's a young person, that would be important. And then we would say, is there a family history? Yes, there is. And you want to know how severe was their family affected. So they may say, well, my dad lost 2 fingers, my uncle's lost a few fingers. And so you're starting to build a picture. This is a young person with Dupuytren's that might get a very aggressive form. And so my personal opinion is you can either do nothing for them and say, we just watch and wait, or not necessarily with this benigner disease, but if it was a bit more involved in the palm, and perhaps they were diabetic and it was a bit more infiltrated, I may offer radiotherapy. And so there's no randomized control trials for radiotherapy, but there is some evidence, and it's mainly in the German literature for radiotherapy. But it is something just for you to start to talk about. And obviously the risk associated with radiotherapy is a theoretical risk of malignancy, causing a malignancy for a benign condition. That would give you some concern. So you need to consent the patient for that. And they can cause redness and a bit of dryness of the hand. And generally speaking, radiotherapy is 5 days of daily treatment. It's only about 15 minutes. It's painless. They just put the hand, keep it still. And then they wait 5 weeks, and then you do 5 days treatment again. But that's just something for you to talk about. And you could say it's not common in the UK, but certainly in Europe, particularly in Germany, it is quite common. But I think a standard question would be to say, well, I'll just watch and wait on that, just to make sure that if it develops, to come back and see us when they can't get their hand flat on the table. And that's called the tabletop test, or the Houston tabletop test. And that would suggest probably about a 30-degree of MP joint contracture. And so now here's an advanced case of Dupuytren's disease. You can see both little fingers are over 90 degrees. And we're going to start to tell patients that it just looks really thickened. And this has just got difficulty written all over it in the palm. You may get lucky, and you may be a really nice cord that will come out and the finger will release nicely. But when I start to see little fingers over 90 degrees, I start to warn my patients that this could be a very difficult correction. for you with a high risk of recurrence. And we'll start to talk about the types of treatment. So we've talked about radiotherapy. We can talk about collagenase injections, and they were really effective, but that's been withdrawn now about 12 months ago for commercial reasons, because it was used to treat cellulite. So it wasn't for clinical efficacy or cost or anything like that. It was just more profitable for it to be used for cellulite than it was for Dupuytren's, which is obviously comes a great disappointment to patients and to clinicians that used it. So that's not available now. And something that another enzyme I'm sure will come along in due course. The other option is PNF, percutaneous needle fasciotomy. It's got quite a high recurrence rate, but for some patients it can be really effective. So if they've got a very discrete, isolated cord, you can simply, with a needle, just pepper that cord in clinic under local anesthetic and get a pretty good release. And there's plenty of people doing that with really good long-term results. And then ultimately the surgery, and surgery can be a fasciectomy where you do a zigzag incision up the finger called a Brunner incision with one N, Brunner, or you do a longitudinal incision with a Z-plasty at the end. So you open up the finger, you identify the neurovascular bundles on either side, and you remove the Dupuytren disease. You then close the skin either with the Brunner or with a Z-plasty. And if you mention the word Z-plasty, there's only one thing that's going to happen, and the examiner is going to say to you, do you know how to draw a Z-plasty? So if you do, great, say Z-plasty. But if you don't know how to draw a Z-plasty, then just say the word Brunner. But generally speaking, it's a pretty slam dunk, easy, low-lying fruit is to say Z-plasty and then just draw them a Z-plasty. Now then, if we turn the hand over, you'll get Dupuytren disease on the back, and these are called Garrett's pads. And then if the patient has got their shoe off in the clinic, it's highly likely they've got pads called lederhosen. If their flies are undone, they may have it affected on Peyronie's disease, but that's very unlikely in the exam. So look for elsewhere, soles of the feet, backs of the hands. And when the examiner changes the subject, they'll often say to you, we're going to change the subject completely now. So that's when you can then just start thinking, right, okay, it's another, it's like a round of golf, it's another hole, right, okay. Change the subject now. This patient presents with pins and needles in their right hand, in the thumb, index, and middle finger for the last year, getting worse and worse, and it's now starting to it's keeping them awake, and it's getting really numb, and they've burnt themselves. What do you think is going on? And so you would say that this is an advanced case of carpal tunnel syndrome, probably. You can see that there's a burn, and you can see that there's marked thenar muscle wasting. And they will start to ask you what the innervation of the thenar muscle is, and abductor pollicis brevis is the only muscle that's purely median nerve innervated. And then they may say, well, how are you going to manage this? And you're going to discuss the options. And it's at this point, it's worth putting in Montgomery. So some mention the word Montgomery. And Montgomery was a ruling where patients had to be given all the options of their treatment. And it's good practice, isn't it, to give patients all the options. And it's not just able to give them the options, but you need to tell them the options in a way that they understand. So you can't just talk medical jargon to patients anymore. You've got to make them fully understand exactly what the implications, the pros and cons of each of them. And, lots of us have been doing that for many years. So it was not new, really, Montgomery, to lots of clinicians. But you've got to now document it, that you've discussed all the options. And one of them is always do nothing. And then you can go through all the various options. Cortisone injection, I don't think that's going to be particularly effective in this case. And so you're going to say a carpal tunnel release. And I actually got asked how to do a carpal tunnel release in my exam, which fortunately I'd done a few, and it was a relatively straightforward. So that's the level of questioning that I was asked. And then in this case, I would say, well, what's the likely outcome going to be? And I think it's reasonable for us to say that the patient's going to have, some improvement in protective sensation, although may not. But I think the thenar muscle wasting may maintain, and they may always have some weakness and clumsiness of the thumb. Just for the sake of time, we'll skip this. It's just a bone cyst. MRI scan shows it. volar wrist ganglion, we'll miss that. Now this is a case, so immediately people will say, rheumatoid arthritis. Just before you jump into rheumatoid arthritis, just have a look at the rest of the hand. So the fingers all look pretty normal, the wrist looks pretty normal. The MCP joints look a little bit swollen, they look a bit subluxed. And this is the X-ray, and this is SLE. So when you're presented with this X-ray, don't just jump straight into rheumatoid. You're probably not wrong to say that as a differential diagnosis, but the examiner might say, oh yeah, well, rheumatoid, it could be, but what do you think about the wrist? And immediately they're telling you to look at the wrist, and is that a rheumatoid wrist? And it's not. And they then may say, well, what else could it be? And it would be difficult if you haven't listened to this lecture and you now know SLE can cause this. And this would be a more typical picture of an inflammatory arthropathy. And you look at the wrist and you say, oh yeah, that's severely affected. And this would be a typical rheumatoid patient with all these rheumatoid nodules, subluxed MCP joints. I hope I've included the slide, which I may or may not, but if I haven't, I'll say it now what I'm going to say, and I'll repeat it if the slide does come up. When you get a rheumatoid hand, which one of you will in the exam, the ulnar nerve, rheumatoid, Dupotrons, they're just the go-to. They turn up for every single exam. So with a rheumatoid hand, I want you to look for scars, because the patients heal very well and scars can be extremely well hidden. So I want you to look on the back of the wrist dorsally for a midline scar for either a synovectomy, a Darroch's procedure, which is excision of the ulnar head, a wrist replacement, or a wrist fusion. Back of the wrist. I want you to look across the knuckles, the MCP joints, either transverse or longitudinal. And that could be for extensor tendon realignment, synovectomies, or MCP joint replacements. I want you to look on the MP joint, because that's a common place where they get MP fusions. And I want you to look on the front of the hand for a carpal tunnel release. And so those are the really common areas for rheumatoid. So when I get a candidate and I say, can you look at these hands? And they say, well, I can see that this looks like an inflammatory arthropathy, either symmetrical or asymmetrical, whatever. I can see there's lots of look like rheumatoid nodules. They could be gouty tophi, but they look more like rheumatoid nodules to me. I'm just going to look for some scars. And already the examiner's thinking you're on a higher level of thinking. You're thinking one ahead of the previous candidate, and that's kind of where you want to be. You want to be one ahead of the previous candidate rather than one behind them. Here's this slide, I did include it. So these would be classic signs on the back of a rheumatoid wrist for synovectomy, realignment, fusion, replacement, Darroch's, that kind of stuff. And then a transverse incision for their MCP joint replacements. With a rheumatoid, when they come into the room, you're probably not going to be able to shaking patients' hands anymore because of social distancing, but you want to offer your hand out to the patient, and then the patient would come to you. So you don't want to be shaking patients' hands either in clinic or in the exam, because hands are painful. And if you cause the patient some discomfort, immediately you're on the back foot and it's really difficult to recover. So kind of put your hand out or even put your elbow forward, whatever. But when you're putting your head forward, just turn to the side and try and look for any rheumatoid nodules if it's a rheumatoid hand. Because if you see rheumatoid nodules and the other candidates happen, you're scoring points. So rheumatoid patient, just look to the side and even, possibly even put your hand underneath just to have a look to feel for rheumatoid nodules. This is the back of a rheumatoid hand. You can see that they presented with some swelling, and I think they presented with a finger drop. We've opened it up a bit more. And this is called a Vaughan-Jackson, where they've ruptured their extensor tendons on the back of the DRUJ, which has got a sharp osteophyte. And here you can see them. For this type of patient, we can do tendon transfers. Just debrided, did a synovectomy, and we smooth off the roughened bits of bone, and sometimes even do a Darroch's procedure. And I think I've just done buddy strapping there. I'm not entirely sure what I've done there. I may have even done a tendon transfer EIP. And that's just showing that for the little finger, we used to do these with the patients asleep, but we would certainly do this with them awake now. When we used to do them asleep, we used to just sort of over tighten it ever so slightly, whether it was an EIP EPL tendon transfer or something like this, we would over tighten it, knowing that the flexor tendons were stronger, and would then just stretch that out slightly. But now doing this all wide awake, we can get the tension pretty right straight away and show the patient straight away their tendon transfer. So again, that's another use of Wallant type surgery. Rheumatoid patient presents with a dropped finger. We would want to know what the causes are for a dropped finger. And of course, it's radial nerve palsy, if they've got some synovitis up around PIN, if they've got a tendon rupture, if they've got an extensor tendon that has subluxed down into one of the gutters, or perhaps if they've got a trigger finger, or if they've got a locked osteophyte. And the tenodesis effect is really good for the PIN palsy. And it's also, if you hold the fingers up and pull the extensor tendons out of the gutter and ask them to hold it there, you then know that the tendon's intact and the PIN's working, and it was just that the tendon was into the gutter. All right, so that's a really common exam question. This is nail bud classification of the thumb, and I just wanted to kind of just run through each of these for you. So the commonest, oh no, sorry, I've got this out of sleep. So this is a finger swan neck deformity, and we would certainly want you to know what the causes of a swan neck in a finger are. Commonest is rheumatoid arthritis, where they get pannus that erodes away the volar plate. You can have ruptured FDS. You can have a ruptured volar plate injury. Sorry, my brain's starting to tire a bit, so forgive me if I forget any of these. And then you can talk about the treatment options, and those are called Murphy rings, which just put their fingers into a slight flexion and never let their finger get locked. You can see mine locks. I had an old volar plate injury and my finger locks. So I try and keep it slightly flexed. I don't wear a Murphy ring, but that's what a Murphy ring does. Sorry, the thumb's a bit out of sync. So a boutonniere deformity is a really common Viva question. This is where you get a central slip injury and you get an extensor lag at the PIP joint and hyperextension at the DIP joint. And I'll explain to you why. And the examination for this is Elson's test and this reverse Elson's test, which I started to talk about quite a while ago, but we've never got around to writing it up. I'm sure somebody will write it up one day and put their name to it. But I just like to call it the reverse Elson's because it kind of explains really easy to students, you know, how to do it. So that's the classic appearance: extensor lag at the PIP joint and hyperextension at the DIP joint. This is an advanced case in rheumatoid, and the central slip pulls off. And there's two ways that you can straighten your finger out. One at the PIP joint. One is with the central slip, and then the second way is you can recruit your lateral bands. It won't straighten it out fully, but it will certainly straighten it out to a degree. But if you're recruiting your lateral bands, you will then start to go on and pull on the DIP joint and cause hyperextension. And that's how this all is worked out. Okay. So let me show you now. I like to draw on patients. I like to show them anatomical models so that they fully understand. This is a sportsman. You can see they've got this a rubber wedding ring because they like to play sport wearing their ring so they don't get ring avulsions. And I explained to them, you've pulled your central slip off. And therefore, you can't straighten the PIP joint using it, and you're having to recruit that lateral bands to pull on the finger, which are causing hyperextension at the DIP joint. We always get an X-ray, and you can see they've got a bony avulsion, and we sometimes do an ultrasound scan. This is the clinical test, is Elson's test. And Elson's test, historically, was put your finger over the side of a table and ask them to straighten the PIP joint against resistance. And you would see the DIP joint would tighten up if the central slip was ruptured. And I always found this a really poor test. I never thought it was that particularly sensitive. And so what we decided to do was just to ask them to turn their finger over and do it. And it was far more sensitive and far more floppy with an intact central slip. So here's a video of that same rugby player doing it. You can see they've got an extensor lag, hyperextension, classic boutonniere. We asked them to turn their hand over, show them on a normal finger what I expect them to do. You can see how floppy it is. And now try it on your middle finger, and immediately it tightens up. So I'd like you to call that reverse Elson's test, so that the examiner can then say, well, what was Elson's test? So it just can't. So this is thumb, back to thumb. Boutonniere is the commonest type. Z deformity of the thumb. Type 2 remembers mixed, Boutonniere and swan neck. Don't know how that worked, but anyway. Type 3 is swan neck of the thumb. Type 4 is gamekeeper's thumb. These are just purely descriptive classifications. And type 5 is mutilans. I just want to keep skipping on here. We're getting close to 9 o'clock. Don't want to keep you much after 9:30. So this is a carpal coalition, and the commonest is between the lunate and the triquetrum, and this is common in Nigeria. Now then, the old ulnar nerve. So you need to know the ulnar nerve inside out for the exam, because they're static, stable clinical signs that are often painless, and they come back time and time again. And what I'd like you to get from this picture is that the little finger is sticking out. This is called Wartenberg sign. And this is the paralyzed adductors. And therefore, there is the unopposed action of the radially innervated EDQ that is pulling the little finger out. Okay? So the patient cannot pull them together. So with ulnar nerve, we ask the patients, can you cross your fingers? And that's pure ulnar innervation. And of course, we all know Frohman's sign, where we ask them to hold a piece of paper and then they recruit FPL. So you're all familiar with Frohman's sign. That's really important that you get across. But this is a really subtle one. So this is this little finger escape sign. And even if it isn't there and you know they have an ulnar nerve lesion, I want you to say, I think that little finger might be sticking out a little bit. You know, I think it might be a Wartenberg escape sign. And the examiner immediately is going to ask you, well, what's that? And you'll then be able to tell them. And obviously you would then look for hypothenar muscle wasting as well. So now you can see on this patient, there's a laceration proximal to the wrist crease over the ulnar nerve. They've got flattened hypothenar muscles, because that's wasted. On the left picture, you can see that they've got wasting of their first dorsal interosseous. So almost certainly they'll have a positive Frohman sign. Now, even I, as the biggest bullshitter in the world, would probably find it difficult to say that that little finger was escaping, was sticking out. So what you would do in this situation is you would pretend there was a wasp in the room and you'd kind of duck down. The examiners would look away. You'd then move the finger sticking out and you'd say, oh, look, they've got a little finger sticking out, which is the Wartenberg escape sign. What I'm trying to get across to you is just mention it and the examiner will ask you about it, and then you're scoring points. Don't mention it if you don't know about it. That would be stupid. If you know about it, set these traps for the examiners. And I make it sound easy, and I don't wish to make it sound easy. But as you start to get confidence verbalizing about pathology, just start to learn about what common questions get asked. Ask your friends and your previous colleagues, what were you asked? And set these traps, not mean traps. The examiners like them because they want you to be a confident candidate. They want you to direct the level of questioning, all right? And I don't wish to patronize you, because it's a really tough exam. It's a fair exam, but it's a tough exam. But I want you to take control of the exam and start to make the examiner's job easy for them. Now, this would be a difficult case, and it's a short case, because, where do you start? Do you go range of movement? What do you do? So you can always go back to Apley's look, feel, move. And always have that in your mind. When you're panicking, the wheels have come off, you've got a complete blank, you don't know what anything is, you don't know what left and right is. But earlier in your brain thinking, before left and right was taught to you, you knew about Apley, look, feel, move. So just go back to that and say, right, okay, well, what did Apley say? Look, right, let me look. So then just start to talk about this. And you could say that this is symmetrical or asymmetrical. So you'd say this is symmetrical. Is it affecting one joint or more than one joint? Well, it's lots of joints, so it's symmetrical poly. And it looks like it's arthritic. So this is a symmetrical polyarthropathy. And immediately you're taking yourself to being a potential gold medal candidate. From 30 seconds ago, having no idea what the hell this could possibly be and how you're going to approach it. So now when you've gone with this, you're now starting to sound pretty smart. This is a symmetrical polyarthropathy, da-da-da-da-da. The examiner's go, okay, so would you like to examine them? So part of look, you're going to start to talk about scars, whether there's scars or not. Then you could talk about feel. But before you get onto all that, because that would be very difficult with this, you can start to say, I want to go to function. I want to see what this person's function like. And so in your pocket, you would have a key, you would have a pen, so you can do the various grips. And we usually like to talk about 5 grips. So we've got precision grip, key grip, tripod grip, power grip, and hook grip. And so we're starting to now be able to talk about this case. And cases like this, and another case I'll show you in a minute, I call them the oh shit case, because, and I apologize for swearing, it's when you walk into the exam, you're like, oh my, what is this? How am I going to approach this? And so immediately you just start to say, right, Apley told me, look, feel, move, I'm going to go for function. And before you know it, 3 minutes has gone by. The examiner's thinking, you know what, that was a pretty tough case. Let's just move on. They did really well on that. So always think Apley, look, feel, move, and then go for function. And that was their x-ray. And this would be another case where you think, where am I going to start? Well, you can start to say, this is a symmetrical polyarthropathy, and it looks of a very destructive nature. I can see this telescoping of the finger. So I think this is probably mutilans. I think this is psoriasis. And then you're going to straight go to perhaps assess them for instability and go straight to function. And there we see that penicillin cut deformity. And then these are dystrophic nails. You can see psoriasis on the back of the PIP joints and with dystrophic. And use the word dystrophic, it makes you sound quite academic. And you can see here, again, a psoriatic patient, quite a lot of shortening of the index finger. That index finger looks quite thickened and indurated. I'm sure it's got quite a stiff, and splinter hemorrhages there on the nails. And pitting. And the reason why they get pitting is because they get dirt and grime go into the pits, and that's why you can see them. Very difficult to get those out. Nail ridging as well. So that would be for psoriasis. This is gout. So this is another type of arthropathy, and you can see the gouty tophi there. And you should understand about how to manage gout. Base of thumb osteoarthritis. Occasionally you get them as patients in the exam, but they're often very painful. So we tend not to get them in as candidates because they're sore. And what we'd like you to talk about here is how you would examine them. And they've often got quite a prominent base of thumb, and we call it shouldering. And if you press on the base of the metacarpal, that causes some discomfort. And that's all you really need to do for the examination of the thumb CMC joint, is just elicit tenderness. You should also look at the thumb MP joint to make sure that's not hyperextending, because in advanced cases you can get a Z thumb. So we want to know whether the MP joint hyperextends. And I'm going to show you in a slide in a minute. We want to also, for the gold medal candidate, to tell us whether they think the ST joint is affected underneath. And the way you do that is by radially and ulnar deviating the wrist. With radial deviation, at the end of FCR is a bony lump, and that's the scaphoid flexing. And with ulnar deviation, the scaphoid extends and goes away. So flexion, radial deviation, it flexes, ulnar deviation, it extends. And that's the scaphoid kind of, rubbing on the undersurface of the trapezium. So a really great candidate would say, well, they've got pain at the base of the thumb, and I'm just going to see if their ST joint is affected clinically. Can you radially and ulnar deviate for me? Now, it's not particularly sensitive, but it'd just be a great thing if you could do without even touching the patient. And they say, oh yeah, that is sore. That. In fact, no one's ever done that before, and show me that. You are just scoring it's like a bingo hall. Like the cash is coming raining from the skies. And this would be a radiograph I'd want you to show, which is called a Robert view, which is a pronated view, which shows the CMC joint very clearly. It shows the intermetacarpal osteophyte very clearly, and it also shows the ST joint very nicely as well. So that's the Robert AP view. This is a trapeziectomy. We could talk about treatment options. This is a trapeziectomy, and we're talking about surgical options. Over 60, you're probably talking about trapeziectomy. And some people do LRTIs and ligament reconstructions, but generally speaking, the work out of Nottingham has shown that just a simple trapeziectomy is as good as anything. Below 50, I tend to do a fusion, CMC fusion, in isolated CMCOA. And between 50 and 60, it's kind of dealer's choice on how physical they are. So a very, very, petite and non-particularly manual 52-year-old might want to get a trapeziectomy, whereas a very bulky 58-year-old may be more inclined for a fusion. But then arthroplasty is starting to come around now. It's not particularly common in the UK, but it's very common in Europe. And you may want to throw that in, but that would be certainly quite new, and it's prone to complications. And it would be something you might want to say, I've got not much experience, but I'm aware that there is some work coming out from Europe that is showing that it can be effective. And that's as far as you'd go. But what would you do as a clinician? I think over 60 trapeziectomy, below 50 fusion, and then between 50 and 60, it's dealer's choice between you and the patient what you would like to do. And one of the complications of trapeziectomy is this proximal migration of the metacarpal. And when this occurs, it can be very, very difficult to resolve. And this is the thumb metacarpal grinding now against the trapezium. And this is another complication, is a slightly aggressive trapeziectomy where they've taken the trapezium out and then they've gone on to take out the scaphoid as well. So, in your early stages of your career, you certainly want to be doing this under X-ray control. And as you get more and more experience, you may not need to do that. And then this is this STT osteoarthritis. So this is where you'd ask the patient to radially and ulnar deviate to see that the scaphoid wiping on the undersurface of the trapezium. And I think the treatment for that, surgical treatment, certainly would be quite an advanced question, and not one that I would expect a level 1 consultant to necessarily know. So always start off with do nothing, cortisone injection, Okay, let's move on. And so this is arthritis in the wrist. The one on the left is secondary to scaphoid non-union, so we call that a SNAC wrist, scaphoid non-union advanced collapse. And then on the right is a SLAC wrist, scapholunate advanced collapse. So the one on the right is a scapholunate ligament injury, can go on to OA, and the one on the left is secondary to a scaphoid non-union. And the treatments for these are the usual do nothing, cortisone injection, proximal row carpectomy, but we think that the capitate should be intact as well as the lunate fossa. So you take out the scaphoid, the trapezium, and the lunate, allow the capitate to drop down and articulate with the lunate fossa. And the exam answer is that the capitate should be in good shape and the lunate fossa should be in good shape for that to work. But we do know that in some cases, we can still do it if the capitate head does look a bit ropey, if it's polished. Okay, so that's a proximal row carpectomy. The other option is a scaphoid excision and a 4-corner fusion, where you take the scaphoid out and then you fuse the capitate, hamate, lunate, and triquetrum. Other options would be a total wrist fusion and very occasionally a wrist arthroplasty. And you want to sort of discuss the pros and cons of use of terms like motion preserving for partial fusions of PRC, and obviously a fusion would solidify them. And then this is just primary osteoarthritis with a normal scapholunate interval and no fracture. This is a failed cervicophalangia where they've tried to fuse the ulnar head to the radius, and then to preserve motion, when they tried to do it, they've excised some of the ulna to allow rotation. But the problem with this is, and the problem with a Darrux, which is where you just take the ulnar head out, is you can get the ulnar stump can start to impinge against the radius, and you can just see along the radius, the ulnar border of the radius, you can see some cortical erosion there, and this can be quite intractable pain. So the complications of a Darrux procedure, which is excision of just the ulnar head, or this, which is a cervicophalangia, is ulnar stump instability, and that can be a very difficult problem to deal with. And the exam answer is, you try not to get there in the first place. So the only people that are suitable for a Darrick's procedure, generally speaking, are sort of low demand, elderly rheumatoid type patients. And in that case, it can do fantastically well. That's not to say we don't do it in younger people, but we proceed with caution because of the risk of ulnar stump instability, and they should be warned about that. So this is a cubital tunnel release, and this is just to talk to you about what structures you might see on your way down to releasing the ulnar nerve. And this is the medial antebrachial cutaneous nerve. So if you cut through this, you may cause a neuroma, but also you would cause some numbness over the tip of the olecranon. And this was actually one of the first cases I ever did at Wrightington in 2001, when I was John Stanley's fellow. And he said to me, as I was about to do it, "Are you okay doing a cubital tunnel release?" I was like, "Yeah, sure, I've done loads." He said, "Just watch out for the medial antebrachial cutaneous nerve." And I was kind of like, "The what?" And I opened it up, and there it was, sitting, looking right at me. And I'll never forget this case. It was my first week with him. So there you go. So you should always try and look that. You don't often see it. Sometimes you don't see it, but when you do, you certainly want to protect it. Look, you know about a ganglion, so it's slightly more distal than one would expect. And I like to show this as a ganglion because it's a sort of a bilobed ganglion. And all I want to talk to you about is why it's bilobed and it's EPL. And then I'll talk to you about EPL, and then I'll talk to the candidate about what compartment EPL is. And then I'll talk to them about the various compartments and what pathology can be into each of the compartments. So don't be surprised if the examiner puts up something like this, start to talk to you about it, and then very quickly the picture becomes completely irrelevant. It's kind of like, it's just an introduction to a topic. A mucus cyst, and it's really important that you mark digits and you mark the finger that you're operating on. This brings into the, about safety. Safety is absolutely paramount to us now. It always has been, even more so. And this is a simple mucus cyst. You've got to excise the underlying osteophyte as well as the cyst. And these mucus cysts can press on the nail bed. Remember, it's on the germinal matrix, which makes the nail grow, and then the sterile matrix is more distal. So once you relieve the pressure of the mucus cyst on the sterile matrix, on the germinal matrix, the nail will often grow out normally. And these can be quite, upsetting for some people, who may have had a long history of really, pretty nails, and they just don't like the way it looks. This is a dumbbell synovitis on either side of a carpal tunnel, and you can see there, you can see longitudinal vascular markings on the median nerve, showing that the nerve's probably going to be okay. This is CRPS, loss of normal skin creases, this shiny appearance to the CRPS. Know a bit about CRPS, know about the treatment options. Mainstay is early identification, aggressive early hand therapy, optimize analgesia, early intervention with the pain specialists. And olecranon bursa, you wouldn't really do much about these. Very occasionally you can aspirate them, but you should tunnel the needle underneath the skin. Do not put the needle in through the tip, because you could cause a sinus. And these can be very, very difficult sinuses to deal with. It's a high pressure system. It will just refill. So if you are going to aspirate it, which, I probably wouldn't even suggest you do it, tunnel the needle, away from where a sinus could form. Ulnar plus variance, this is secondary to an old distal radial fracture. That's how we measure it. Treatment options, ulnar shortening osteotomy, if the DRUJ is lined up reasonably well. Ulnar-sided wrist pain. The first thing I actually go to, I obviously feel, but I feel the foveal soft spot, but don't forget the pisiform, and get the pisiform and shear it sideways, because if that's pain-free, you can then lock out the pisotriquetral joint to then check for the lunotriquetral instability. So PT arthritis is more common than you actually think. This is probably the only X-ray of it in the world that shows it. It very rarely shows up on X-ray. You can do carpal tunnel skyline views, or these oblique views, but often you've got to take a bit of time getting it right. And clinical examination will often tell you the answer, and an MRI scan also will show you an effusion and loss of cartilage. And the treatment for that is a simple pisiformectomy, taking care not to damage the neurovascular structures. This is ulnar abutment on an MRI scan, and when you see bruising like that, plus an ulnar plus variance, the treatment option is probably going to be an ulnar shortening osteotomy. Anterior interosseous nerve palsy, know a bit about that. I want to keep moving. This is an old septic. I'm not sure whose slide this was, the one that John Stanley gave me. An old flexor sheath infection. The pulleys have all been destroyed and they've now got bowstringing. So understand about the pulleys and understand the important ones are A2 and A4, but also appreciate that the recent work by Boateng has suggested that, we can vent these when we're doing flexor tendon repairs to an extent. Implantation dermoid, I think. This is hemochromatosis. So hemochromatosis is a iron storage problem which causes osteoarthritis in the MCP joint. So when you see this, it's probably the only time an elective hand surgeon can save the patient's life. You would run iron studies. The differential diagnosis here: hemochromatosis, primary osteoarthritis, and septic arthritis. So it may have been an old fight bite injury that I showed you earlier. Mucus cyst, again, let's keep flicking on. Paronychia, glomus tumor, thermoregulatory. So cold weather, put the finger on an ice cube. The important thing about this is MRI scan often shows multiple lesions. All right. Implantation dermoid, you can see that little tiny punctum. And whenever I excise lumps off people, I tend to dot around the lump, because if you're using a tourniquet and you squash it, sometimes the lump's not there. And if you've got an asleep patient and you can't see the lump and you can't remember where it was because you've got 6 on your case, that you saw them at 8 o'clock, you've got a big problem. So I really urge you to dot around any lumps so that doesn't happen to you. That's a neuroma in continuity after old Dupuytren surgery. I don't even know what that is, but it would just be put there for us just to discuss about differential diagnosis and how you would examine it and how you would investigate it, transilluminate it. Has it got a pulse to it? Has it got a thrill to it? It's endless what we could talk to about that. And then the last few slides now are when you get a lump in an unusual place in the hand. The commonest lump is a ganglion, obviously, but if they're in a slightly unusual area and they're not really respecting normal anatomical boundaries, you've got to think about giant cell tumor of tendon sheath. And that's the second commonest lump in the hand. So a GCT, the histology is the same as PVNS. And this is a tiny one. It's got this brownish tinge to it. And then here's a slightly more florid one going along the finger. And we had that superb lecture from Lee Jays a few weeks ago, about tumors. And I asked that question about, tumors in the hand. And I've only ever seen a couple, and they both presented with quite significant sensory symptoms. So it was almost like the tumor was, sending out some toxic environment that was irritating the nerve, and he sort of confirmed that, didn't he? But this is a GCT, so this is a benign condition, so it won't metastasize, but it's locally aggressive. So you always warn the patient, and usually for something like this, we would have done some preoperative investigations, such as an MRI scan or an ultrasound scan. So I think we're just coming to the end with a bit of congenital. We've got someone lined up to do a congenital hand for you as well. So delta phalanx, the thumb. Trigger thumb in children, 90% of them resolve by the age of 3. So, don't shoot in straight for surgery on this. Duplication, and these are 2 little tiny duplicated digits. Duplicated thumb, the Wassel classification is the one you need to know about, and it's type 4 is the commonest. This This is congenital Madelung's deformity. This is congenital clinodactyly, little fingers curved over. There's mum. Macrodactyly, had previous surgery. And this is radial longitudinal deficiency. And this is a really good exam question because of all the associated syndromes. And, you know, we expect you to know all those. If I was doing an MCQ at the end of this, which I'm not, you will be pleased to know, you know, this would be one of the questions. You know, if I was going to do 10 MCQs, you know, my congenital would be what are the associated features with, you know, Holter arm or all of those, okay? This is Kerner's, where the little finger distal phalanx is curled over. This is absent flexor crease. The one on the right, on your right, as you're looking at it, has only got one crease. And creases occur at joints. So when there's no creases, there's no joints. This is Madelung deformity. The so-called Vickers ligament on the volar ulnar aspect of the radius sort of tethers the growth plate down. The radius along the radial side grows normally, the ulnar grows normally, and that central part is tethered and held back. This would be a good, you know, question about zones of transmission. Is this benign? Is this malignant, etc.? And Lee covered all that. These were two brothers, came in to see me years ago when I did pediatrics, and one of them had fallen off a swing a few days earlier, was in a lot of pain, was diagnosed with a dislocated elbow. Luckily, his brother was there with exactly the same shape elbow. This isn't their X-ray. This is a true traumatic dislocation. You can see I've got them out of sync. The radial head has anteriorly dislocated, and look at the shape of the radial head. You know, it's flat, if not concave, because it has articulated at some stage with the capitellum. Now compare that to little Billy's radial head, which is here. Can you see that? How he's got a convex radial head. So his radial head has never articulated with the capitellum and has therefore never become concave. So I was able to reassure mum that this was not a dislocation. And it was fine because after a couple of days, his elbow was moving fine, as was his brother's, and they both had congenital radial dislocated heads. And in those, in the traumatic ones, so I've got these out of sync, not concentrating earlier. In the traumatic ones, when they present late, you've almost always got to do an ulnar shortening an ulnar corrective osteotomy. And then I think this is maybe the last slide. It's just about cortisone injections. You know, in the hand, it's just a plea to all of you who don't eventually do hands, is keep the volume, keep the dose down. Whilst it can be effective in some situations, it can cause quite significant lipodystrophy, bleaching, and you can see she's got skeletalization of her extensor tendons there. And then on the when this was given for tennis elbow, clearly it's very rarely given for tennis elbow anymore. A lot of bleaching in the lateral aspect of the elbow. So if you are doing intra-articular corticosteroid injections, you know, keep the dose down, maybe 4 milligrams to 10 milligrams of Canalol. And I think that is it at 1 hour and 25 minutes. So, Jishan and Kat, have you fielded any questions? You've sorted everyone out for me?
Yeah, there's a couple of questions. First is regarding fight bites and how you would approach the joint and whether you would go through the sagittal band and would you repair the sagittal band? So,
good question. In these situations, the tooth will have probably done your surgical approach for you. Yeah. So you're going to extend the skin incision and open it up proximally and distally. You're going to elevate the skin. You're then going to see a defect in the sagittal band or in the extensor tendon. You will then extend that distally and proximally, open up the extensor tendon, lift it off, and you'll be then exposed with the joint capsule. The joint capsule then is either violated or not violated, probably will be, because, you know, remember, a punch at speed against a sharp tooth or against glass or against anything doesn't usually stop cutting until it hits bone. So it's highly likely that it will have violated the capsule. Open up the capsule. If you got them super quick, within an hour or two of it happening, and you've got them straight to theatre, you've washed them out, there's possibly a chance that you could say, I would primarily close the various structures. You may say, I'll leave the capsule open, but close the skin and close the extensor hood. But you may also say, well, actually, in the exam, play it safe. It's a fight bite. I'm just going to wash it out, IV antibiotics, and bring them back in a couple of days' time and close it. And I think that's what you would want to go for as a day one consult.
Then the second question is, in the absence of acute carpal tunnel, need to a lunate or a perilunate dislocation at midnight, or can it be done in the morning?
So you just dropped out a bit. So that was in a perilunate dislocation.
Sorry, yeah, in a lunate or perilunate dislocation, in the absence of carpal tunnel symptoms, do you need to reduce it in the middle of the night, or can it be done in the morning?
So I think, it's another really good practical question. That would be a really good question to ask. Probably an advanced candidate. What are you going to do with this? I think it's reasonable to if the patient's comfortable and they've got no neurological symptoms, you could possibly wait till the morning. But a simple thing that you can do is just get some finger traps from theatre and put some finger traps over my brain's completely gone blank, but over a drip stand, and then just allow the weight of the patient's hand. It will disimpact. It will give them some analgesic as it's been disimpacted, and not almost certainly, but maybe it will actually reduce spontaneously over the next hour or two. And then just do an X-ray pre-ward round, or once it's back in, they would probably be able to move their wrist reasonably well. So I probably wouldn't be opening up a theatre in the middle of the night to do something like that.
And then I think there's just one final question. Somebody wanted to know about the best way to excise a mucus cyst.
So the best way to excise a mucus cyst, there's a number of incisions that you can do. You can do a H incision, you can do a T incision, you can do a wine glass incision. You should do them probably under local anaesthetic with a digital tourniquet. You elevate the skin flap. You sometimes see the cyst, and the cyst is usually coming to the side of the extensor tendon. And so I tend to go down the interval between the extensor tendon and the collateral ligament. I excise the cyst. I then am down to the joint, and I get a little tiny bone nibbler rongeur, and I nibble the underlying osteophyte that is probably causing the mucus cyst in the first place. Very occasionally you'll get quite a destroyed joint. It's arthritic all the way across. And so you want to be really careful that you don't damage the extensor tendon with too aggressive bone nibbling. But generally speaking, they tend to resolve once you've removed the osteophyte. But of course, you're not changing the natural history of the underlying joint. They can reform, and the joint can become degenerate in the future. And you may need to offer them a surgery such as a DIP joint fusion, which I didn't cover today, but we couldn't cover all of hand surgery in 90 minutes. But I think we did a good effort, though.
Yeah, really good effort. And I think that's all the questions, actually.
Great. Well, thank you, everyone, for tuning in. Next week, I'm away, and it just depends on whether I can get Wi-Fi. And I think we may have somebody else lined up, but future talks, we've got Alder Hay. They're going to be talking about pediatric orthopedics over 2 weeks. So that will be great, because it's a really important part for the exam. We have our pelvic trauma team at Wrightington, who do our regional trauma service. They're going to be talking to you about pelvic trauma, and also about the basic science about massive blood loss, which I think is a common exam question, and some of you have been asking about that. please do email us if there are any topics you want covering, because we're only as good as you let us be. So tell us what you want to be educated on, and we'll try our best to cover that for you. So it's 9:30. If there's no further questions, I hope everyone's had a nice weekend. If anyone is trying to go away on holiday, I hope you do manage to get away on holiday. Sorry, this is all happening to us. It's terrible, and it's even, it sounds like the second peak's coming now. So everyone be really safe, and please do adhere to us, the guidelines and everything.
Thank you very much. That was a fantastic webinar. We're getting feedback from people saying the same thing. So thank you very much. Yeah, hope to see you soon. Bye.
All right. Well, maybe we'll see you next week, and I'll post it on BOTA will put it on their website as well, and I'll put it on my Twitter. Okay. All right. Sleep well.
Thank you.
Cheers.
Bye.
Bye. Bye.